So everyone, so I'm Rebecca and I'm the research fellow for the study which we're going to talk to you about today, and this is Wez, who is one of our peer navigators, and thanks very much for coming along today.
Peer navigator, sorry.
Yeah, sorry, I'll try and, yeah. So we're going to start by introducing the study and the theory of Normalisation Process Theory, or NPT, before sharing how the peer navigators are using NPT to make sense of the roles and practices as peer workers and share their experiences, such as how they're getting on in the services. So the research study, supporting harm reduction through peer support, or SHARPS, and that's actually a shortened version, it's much longer than that, is funded by the National Institute for Health Research, the NIHR, which is the research arm of the NHS. The SHARPS study team includes experts from the University of Stirling, NHS Lothian, the Scottish Drugs Forum, the University of Aberdeen and the University of Victoria in Canada. And as Tim said, involves key partnerships with the Salvation Army, but also Sarvenians and street work. So SHARPS is a 2-year feasibility and acceptability study to develop and test the use of a peer-to-peer relationship-based intervention. Again, that's a shortened version. The intervention is informed by the concept of psychologically informed environments, or PIEs, which you've heard a lot about in this conference, as we should. And the intervention focuses first and foremost on the peers developing trusting and supportive relationships with their participants. And these participants are individuals who are over the age of 18, who are homeless or are vulnerably housed at risk of homelessness, and who self-identify as having a problem drug or alcohol issue. And the next step involves the peers working closely with these individuals to support them to address a range of health and social issues, and crucially on the participants' own terms. The intervention has a health and harm reduction emphasis, so the peers are working with participants to help them to improve their overall health with a broad approach to what we mean by health, so physical health, mental health. And they support participants to work on the relationship with alcohol and drugs within a harm reduction framework. So harm reduction aims to support people where they're at, rather than trying to get people to change before they can, or before they're willing. And harm reduction also supports people to improve their quality of life and is more likely to be effective than abstinence-based approaches with this population. So that's individuals who've got really challenging and difficult life circumstances, as we've heard about at this conference. So in the study, these peers are called peer navigators, and they're employed by the Salvation Army. They started in post in June last year and finished up in December this year. 4 peer navigators were originally employed, and 1 resigned and finished in January, so there are currently 3 working with us. All of the peer navigators have lived experience of homelessness and or problem substance use. Importantly, they're making this lived experience explicit to their participants and to potential participants. And they're also actively drawing from this experience, as well as their training and interpersonal skills, to support participants in whichever way best meets the needs of the individual participant. So the peer navigators are based in 3 homeless outreach services in Scotland, in Edinburgh and West Lothian, and in 1 hostel in the north of England in Bradford. And there were 2 hostels part of the study in Liverpool, and that was where the peer navigator who was working there was based. We also have standard care or comparison sites, 1 in Scotland in Greenock and 1 in Sheffield. So the peer navigators are currently working with their caseload, and the recruitment period finishes at the end of this month, and they'll be working with 15 participants each. They've either already reached that caseload or are very close to reaching it. And the aim is to work with these participants closely for about 12 months or near thereabouts, with those who receive the short intervention with the peer navigator who resigned for about 2.5 months. So what's the peer navigator role? The peer navigators are working with participants to find services that can meet their needs, such as healthcare, housing and counselling, and they're also attending appointments with them, including travelling with them on public transport. And the study has a moderate budget to help facilitate that, so that money or lack of it is not a barrier to accessing services. This has been used for bus fares, appointments, to buy hot drinks and snacks and so on. And really important, the peer navigators are also simply spending time with people, getting to know them and supporting them emotionally. So what are the aims of the study? We're aiming to explore whether the peer navigator intervention can be delivered with this population, that is, individuals who are experiencing problem substance use, who are homeless, precariously housed, and who use homeless services, kind of outreach or drop-in services, or hostels. The study will look at whether people want to get involved with the peer navigators, and it will also explore how the peer navigators participants work together. It will also ask staff how they felt about delivering the intervention and being part of it. It won't find out if the intervention actually works. Given the sample size, we can't be definitive, although we'd hope to get an indication of whether or not it has an impact. So this is a research study, that means data. So in order to be able to answer these questions, we're collecting qual and quant data. To get a perspective of how the intervention works from participants, we're involving peer researchers who are volunteers, recruited from and supported by the Scottish Drugs Forum. For those not familiar, it's SDF, the Scottish Drugs Forum is Scotland's national resource of expertise on drugs research and related issues. And these volunteers have lived experience of problem substance use, and they'll be interviewing participants, and they've already done a wave towards the beginning of the intervention and then towards the end. And then more qualitative data has been collected through interviews with the peer navigators, which has been conducted primarily with me and with another researcher, and also with staff working in services, and also staff working in the comparison services to get an idea of how they think a peer navigator might fit in their service, or not at all. And we're also doing observations in all the settings to get a feel for what goes on in the space, what the environment's like, and pies, that kind of stuff. And as well, the peer navigators have been keeping reflective diaries since they started, reflecting on how they're getting on in the services as the role develops. And our quant data is coming from a holistic health check, so that involves working with participants to complete a series of questionnaires, or 6. This again was mainly with me and with another researcher, and we do these checks at the beginning and then towards the end, and the idea is we'd hope to see a bit of change over time, although again, we can't say anything definitive. So I mentioned it's a feasibility and acceptability study. So feasibility, can it be scaled up? Can it work in different kinds of settings, for example, NHS settings, as well as how acceptable it is? So do participants like working with the peer navigator? Do they even want to get involved? Do the peer navigators like their role, and do staff and services like their peer navigator role, or is there any resistance there? The most important outcome of this research is to see if more research should be conducted, and to see if the peer navigator role has a meaningful impact on people's lives. NPT. So NPT has been described by academics and practitioners as a sociological toolkit that can be used to understand the dynamics of implementing, embedding, and integrating a new technology or complex intervention. Now, our understanding of this is that it's a way of understanding why in reality some interventions work and why some just don't, or don't work quite so well. The difference between theory and practice. We've used NPT at the early stages to inform the development of the intervention, and we're using it at the moment, and we'll be using it throughout until its completion. As you can see, there's 4 core constructs of NPT, which are coherence, cognitive participation, collective action, and reflexive monitoring. Coherence. It's the sense-making work that people do individually and collectively when they're faced with the problems of operationalising some set of practices. So in terms of a study, this refers to the value placed on the peer navigator's role by themselves and others. So we need to ensure that everyone knows what the role involves and fully understands the point of it and the core values that inform a study, like harm reduction, PIEs. Cognitive participation refers to relational work that people do to build and sustain a community of practice around a new technology or complex intervention. In this study, we need to understand whether key people are working together to drive the study forward. It's about buy-in. For example, someone in a host service being supportive of the peer navigator and understanding that their role is difficult and offering them emotional support. Collective action is operational work that people do to enact a set of practices, whether these represent a new technology or complex healthcare intervention. So in this study, staff and services might need to reorganise themselves to contribute to this work. But they might literally need to free up space in office to accommodate a peer navigator. Are they up for doing that, or is there some resistance? And finally, reflexive monitoring refers to the appraisal work that people do to assess and understand the ways that new set of practices affect them and others around them. So as I mentioned earlier, reflecting data from a range of sources, but the peer navigators themselves are reflecting on how their role develops as the intervention goes on. Thanks for listening to me. That's an overview of the study in NPT, and Wez is now going to bring all this to life to share what NPT means in practice and just how the peer navigators are getting on in their services. Okay, thank you.
Thanks, Rebecca. I'm very nervous. I'm also Wez, and I am a peer navigator working with some of the participants in the project Rebecca has just outlined. I'd like to thank you very much for coming to listen to me and to listen to us. I'd also like to just, I'm quite amazed that my journey's brought me here. I'm also privileged to have been around so many doctors today, and I'm also quite amazed that I haven't displayed any drug-seeking behaviour all day either, which is a result. I'd like to share some examples from all 4 peer navigators and how we see NPT as it relates to our role and possibly the perception of other services of our role. So first up, we've got coherence, or the making sense of the role stage of NPT. Here are some of the more positive scenarios.
How'd you click it? Sorry.
It's all right. Navigators have received encouraging feedback from staff who have commented that it is a powerful example when someone with lived experience can offer support. This has the potential for increased empathy between the worker and the participant. Also, navigators have been well received by other lived experience workers and volunteers who appreciate that the study may change the perception of peers in general. We also had comments from both staff and participants who noted the informal way in which we engage with people. Examples of this are we do not have to adhere to strict appointment times, making our interactions more flexible. We are also very tolerant of both the levels of engagement and the level of intoxication of our participants. We also had some negative experiences during the initial stages of the project, such as, with this being a pilot study, our role was evolving, which presented a challenge in us building an understanding of our role in the earlier stages of the project. This also led to some difficulty in creating a shared understanding with other professionals with which to move forward. Another one is during conversations with other outreach workers, we learned that they thought this project was exactly the same as other services already on offer. We explained that our role is different because we are able to disclose our previous experiences of both substance misuse and homelessness. Some still do not fully appreciate the lived experience aspect of our role. In the second stage of the MPT framework, or the cognitive participation, which is cognitive participation, or the taking part stage, some of the ways in which people felt positively about taking part in this project are: members of staff who have been invested from the beginning of the project said they understand the importance of the role and the possible benefits to service users. We were often asked how conferences or training went, and at times had been invited to sit in on support sessions and team meetings. Another positive example of the cognitive participation stage is navigators being asked questions about substance use, the effects of various drugs, symptoms of withdrawal, and how things may have changed for them after they engaged with treatment services. Also, staff are seeking advice about situations where they may not have very much experience, and our opinions are being taken on board as our previous experience provides a more informed perspective. A negative experience of this stage has been another service refusing to acknowledge the navigator despite sharing a client with them. A navigator had made repeated attempts to make contact with the service for which no callback or response was ever received. A navigator was also inappropriately asked to leave a multi-agency meeting. The navigator sensed that the study was being resisted with no explanation for this. We now come on to the collective action or the making things happen stage. Some positive examples of this are, in certain services, an intoxicated client would be asked to leave. However, as a navigator was present, the staff asked if he could intervene and speak with the client as they felt they would benefit from someone with lived experience. This provided support for the client at the time and also prevented the client from feeling rejected by the service. Also, being included in support sessions by other workers, allowing us to see current ways of working. This gives an insight into the existing relationships between service users and other support staff. The following example relates to the engagement and commitment of the participants themselves. Participants who feel their navigator has exceeded their expectations have often been willing to try one or more suggestions. Some of the suggestions made could include visiting other services, attending groups or mutual aid meetings. These participants were previously unwilling to engage in this way. Now on to a few of the negative examples of this stage. A navigator was restricted by another staff member in organising donations of essential items for participants. The staff member had felt that as other service users could not benefit from this, then no one could. The navigator felt that this didn't complement the unique relational approach of the study. Another one is navigators not being included in updates regarding their own participants and sometimes feeling they are not fully accepted as part of the team in host services. Navigators have received unhelpful comments about participants, including, "You're wasting your time with them," or "They're never going to change." Some staff seem resistant as they are now asked to accommodate participants within the study and its harm reduction approach, where previously they could have just asked them to leave. Here is another engagement and commitment by participants example. A high level of early engagement could be dependent on the level of crisis the participant is in and the access to services that the navigator can provide. For them, however, this high level of engagement may not be sustainable as the participant progresses and moves away from crisis, requiring less practical support. They may not see the benefit of a long-term positive relationship with the navigator. We now move on to the final stage of the MPT framework. Thanks for bearing with me. This is the reflexive monitoring or the measuring stage. When staff pass on positive views of the work we are doing, this is very encouraging, increases motivation and provides useful feedback. This is a positive example, along with staff in reflective practice sessions sharing where things had gone well or not, which gives the navigators the opportunity to hear how other staff may have approached that situation. As part of the study, navigators have been completing reflective diaries. These can be very cathartic and lighten some feelings and pressure, as well as providing valuable data for the study itself about how it is progressing. These being anonymous also increase the level of honesty that we are able to display. And finally, the negative examples. Navigators possibly disclosing too much about their lived experience in staff meetings or in general conversation. The fear of being judged or treated differently due to the previous lifestyle. In some settings where line management is less frequent, there are also fewer discussions about the positive impact of the project. So in summary, I'd just like to say that all these examples are navigators' own interpretations. They can be influenced by a lot of different factors, such as unconscious bias, changing moods, people having off days, or just feeling unsociable. I would also like to mention that our understanding of the MPT framework and using this helps us to not over-personalise where we may have felt that our roles were either dismissed or viewed in a negative light. Overall, the project has received a largely positive response from both participants and services. I would like to thank you very much for your time and attention, and we'll welcome any questions or feedback. Or are we doing that at the end?
No, let's do that. Yeah.